Okay, good morning, everyone, on a lovely Friday morning in Pittsburgh. This is Tony Stile. I'm a psychiatrist here in Pittsburgh, and our topic today is effective strategies in outpatient methadone treatment, both the legal and clinical issues. I assume you're all in, either through your telephones or your computers. They can read that? Okay, so you can read the audio and question and answer options. And if you have questions or comments or improvements on this talk, please send them and do it according to the audio and Q&A options. Just a quote from previous webinars and from our all-day conference in Chicago from Dr. Flaherty. All medical care involves the management of risk at a minimum. So today I'm going to host the webinar, and Lisa Torres, an attorney, will be presenting first and will be my co-presenter. Lisa is an attorney specializing in civil rights and health care law. She's currently employed by the Division of Addiction Services for the state of New Jersey. She's a nationally recognized expert as an advocate for consumers of substance addiction training and recovery services, and represents this constituency at multiple venues. So I will stop there and introduce Lisa, and please, Lisa, are you there?
Yes, I am.
Okay, you can start, and I'll be in charge of the slides.
Thank you, Tony, and good morning to everyone. My name is Lisa Torres, and I am an attorney admitted in New York and New Jersey. I have been an advocate for medication-assisted treatment and recovery for quite some years now, and I've been involved in the risk management of opioid treatment programs, presentations for, we've been working on these for almost a year now, actually. Today's presentation will involve the issue of impairment. And I must say that I need to have this disclaimer that although I am a lawyer, I am not pertaining to give legal advice per se, because the legal definitions of impairment will vary enormously by state according to various purposes. DUI, driving under the influence laws, are perhaps, we're going to discuss those in this presentation, but also in the context of public intoxication and child care, the issue of impairment relating to patients in methadone treatment surfaces. So this is a generic presentation to help opioid treatment programs minimize the risks of loss associated with impairment. Mostly by patient impairment, but here again, staff are not immune, and so whereas this really focuses on methadone patients, the overall tone of establishing a no tolerance to impairment should apply equally to everyone in the OTP. The objectives of this webinar will be to introduce the issue of patient impairment in the OTP, to identify the different sources of impairment, to look at impairment assessment instruments, and Dr. Stile will help with that. I will discuss the managing loss exposure associated with impairment, basically the risk management analysis and different treatments. We'll talk about policy and procedures regarding impairment, OTP responses to suspected patient impairment, and we'll touch upon OTP liability for injuries involving impaired patients. So we're changing slides here to impairment as a severe risk exposure. This webinar has to do with impairment because it is a severe risk exposure. There are many consequences of mixing medications with methadone, and every OTP should familiarize themselves with reliable and updated sources for methadone for information on methadone interactions with other drugs. These sources are continuously revised and updated as more information becomes available and as more medications are being used, either off-label or on-label, approved for not just addiction, but approved. So my favorite is the Addiction Treatment Forums website at www.atfforum.com, and that's pretty extensive. Impairment is among the most severe interaction, and trends show that impairment is becoming an increasingly likely factor in more frequently filed claims by third parties against opiate treatment programs. And these trends, we had in our initial full-day webinar, had it was actually a great pleasure to incorporate the insurance folks from methadone insurers into that webinar, and some of their trends are what I'm referring to in saying that impairment is becoming an increasingly likely factor in more frequently filed lawsuits, and in fact there are bars that are attorneys in various states that specialize in suits against methadone programs. So we really need to be diligent in making sure we understand how to minimize health safety issues regarding impairment and certainly liability. So we're going to change the slide, Tony. First of all, just for a generic and common law suit of legal definition of impairment, it's not very pretty, but it's the diminishment of a person's faculties so that their senses, their ability to see, hear, judge distances, and also reasoning, their ability to reason, are compromised. They are below the normal or the acceptable level set by the state, and that would be, those levels would vary from state to state. That also means that if a patient is impaired, they can't really give a legal consent because impairment certainly will compromise reasoning ability. So that's something to keep in mind, a favorite issue of mine. And whether someone's legally impaired is going to depend on the degree of diminished capacity and, as I mentioned earlier, what activity is involved. And both of these are established by regulation and also case law, how regulations are interpreted by the courts with various fact patterns is creating the law of impairment and third-party liability. Let's change, please. In the context of risk management, impaired patients present potential dangers to themselves and others if they don't restrict their activities to those they can do safely and without significant risk of harm to themselves or others. Regardless of the source of impairment and the degree of impairment, individuals are prohibited from operating heavy machinery, and that would include automobiles. And this is a universal theme that's going to be repeated throughout my presentation, that OTPs have as a very definite and known policy of no tolerance for impairment, and that this be raised and spoken about and acted upon throughout the day-to-day operations. Identifying impairment in patients is typically grounds to support refusing to medicate, and that's usually that is what I would recommend. The case law has extended liability and found there's been causation found in the fact that patients have been medicated despite obvious impairment, what was obvious to other other observers and witnesses. And also, if somebody appears impaired, or even is suspiciously, maybe a suspicion of impairment, you certainly, and you'll hear this theme too, can delay or defer medication until that risk of suspicion is made reasonable or eliminated. Suspicion of patient impairment can, and after this webinar I hope should, trigger a set of preemptive actions aimed at avoiding and minimizing the risk of potential harm to the patient and to others. Okay, we're going to talk about sources of impairment in methadone patients. I learned a lot in the course of researching for this webinar. A methadone patient who has achieved optimal dose stabilization is not impaired. And I think that's critical to know as an advocate for methadone maintenance pharmacotherapy. We have enormous information and studies and tools that are available to confirm the lack or absence of opiate impairment. And a lot of these are the studies, and there's even an attorney toolkit that Legal Action Center and I believe NCAD New Jersey, the National Council of Alcoholism and in New Jersey has published on its website some really good information for attorneys who are representing patients who are in a situation where they are presumed to be impaired because they are in methadone maintenance. And certainly, if you have a patient who's been long-term stabilized, you would want to pull out all of the data and information and help inform a judge or the parties responsible. Now, that being said, a newly induced patient who has not yet matched or built up tolerance to the methadone dose and whose optimal dose hasn't been established can be impaired. And the induction stage, as you'll see, is an area where in a risk management analysis, impairment is more likely because we're dealing with new patients. You really don't know them, and even though they're giving you information, it may not be verifiable. And we're trying in the beginning of the induction stage to figure out how to medicate the patient so as to relieve withdrawal without over-medicating and subjecting that patient to risk of overdose. And that's an art, and it's why methadone needs to be dispensed by experienced and educated physicians and medical personnel. It's a balance, but the impairment comes from two sources in new patients. Either they're not receiving enough medication, in which case they may appear in withdrawal, and the state of withdrawal itself can bring upon impairment. Or because they're not receiving enough methadone, they may have self-medicated with illicit substances, which would also raise a possibility of impairment. And on the other hand, if they are over-medicated, perhaps they exaggerated how much their tolerance in terms of how much heroin they use or how much OxyContin, and that raises the issue of the possibility of somnolence and lethargy and all of the symptoms of over-medication. So, unless it's done perfectly, there's many sources of impairment at the induction stage. So to continue with the different sources, certain licit and illicit substances and medications, when taken alone, may not produce a possibility or a risk of impairment when taken in combination with methadone can also raise issues of impairment. And this is where the drug-to-drug interactions becomes invaluable. This is where communication with patients and communicating that it is their responsibility to inform all medical providers that they are in a methadone treatment program and to learn and help patients work to share information, critical information, with the OTP so we can help with some of these decisions and inform a patient of a possible drug-to-drug interaction. Alcohol and benzodiazepine are among the most common substances taken with methadone that warrant heightened scrutiny for impairment. And I had a problem. I know benzodiazepine has been an issue with impairment, and so is alcohol, but benzodiazepine specifically, I only recently really came to understand why so many methadone-maintained patients are attracted to and or are prescribed benzodiazepine, and it has to do with the fact that there's a greater likelihood of anxiety disorders among the population of methadone-maintained patients than there is among the general public. It's like what came first, the chicken or the egg, and often there's been underlying anxiety disorders that continue to exist in methadone treatment and to which warrant prescription of benzodiazepine. However, that being said, we know that that there's a higher likelihood of impairment with those with benzodiazepine and also with alcohol. Switching the slides, I'm going to just do a short risk management analysis of the risk of impairment. Looking at possibility, you've heard me use these words just in the last couple of slides. Probability, the likeliness, severity, all of the factors you would use to consider how to intervene and what risk treatment to apply or whether to intervene in managing risks associated with impairment. So during induction, patient impairment is common, and it should be anticipated, and we talked about that. The loss associated with patient impairment is more probable in patients whose urinalysis indicates continued polysubstance use. So those patients who are having positive drug screens would warrant a tighter sort of a monitoring or a screening. For patients who drive long distances to and from the OTP, loss becomes even more probable. And this is a factor I believe we should, to be responsible regarding the issue of impairment and minimizing our risk of injury, loss, and liability. We really should be asking patients how far away how long distances they're driving, whether they're driving alone, because I think that gives us better information in our risk analysis. I think patients, some patients are driving 2 and 3 hours to get to a methadone program or to get from a methadone program to work. And I think these are factors that need to be almost routinely explored. The loss, and that is because the loss associated with automobile accidents often involve third parties and can be very severe. The severity of the automobile accidents is what really warrants us, looking at some of these factors that increase the possibility, probability, likeliness of injury. So, moving along, the next slide. The one sort of universal recommendation that I believe is reasonable in the course of this webinar and to take home from this webinar would be to establish within the OTP, within your programs, an environment, a climate, a tone of impairment awareness. First you have your policy of no tolerance for impairment, and then you're going to start creating an environment where everyone is involved in this tone of being aware of impairment. And I can see an impairment awareness day, an impairment awareness week. Anyhow, we're going to be educating patients. We need to educate patients. We need to bring the issue of impairment awareness to light. We need to educate our patients regarding the various sources and the potential consequences of impairment, which is going to vary state to state. But in the OTP, you're also going to have consequences if someone comes in impaired. They're likely not going to be medicated. They're likely going to be asked to wait, and there are other consequences according to what your policies and procedures are. But you want to educate patients about the sources. They may not know some drug-to-drug interactions or even some psychiatric meds. Seroquel, I think, it really causes disorientation in patients. And you want to educate your patients, give them sources where they can further educate themselves, and invite them to ask questions about impairment. We also want to inform patients of the OTP policy of no tolerance for impairment, and I'm just going to assume that every OTP in the U.S. has a policy of no tolerance for impairment, so they know what to expect. If you're going to inform them of policies that are existing and procedures for responding to reasonable suspicions of impairment. And to the extent you don't have procedures that really include, the consequences and are really easy to understand, you're not going to have patient buy-in there. And in my opinion, the no tolerance and the informing and including patients to revise or help draft the procedures for how we should respond when we suspect impairment is really critical to that to creating that community sort of environment of impairment awareness. So that would be part of this total OTP community effort to observe and report signs, symptoms, and information regarding impairment. That's critical. And moving along to the identification of patient impairment. Although again, I need to reiterate that staff are not immune from coming to work impaired. There are opportunities to identify patient impairment in the OTP that certainly include direct observation, but there's an opportunity, a big opportunity in staff who may not be have the obligations of direct care to patients, but who are nonetheless support staff, receptionists. Many staff have security personnel and folks who collect fees. These are members of the team that have opportunities to observe and identify potential impairment in patients, and they need to be included in this sort of community effort. On the front line of this certainly are the dosing nurses in identifying patient impairment. They're the most important resource, I believe, because they are trained to identify patient impairment, and they have the advantage of observing the patient up closely in a more intimate and private, hopefully dosing stations are that would allow for conversation, that would enable a nurse to smell alcohol on a patient's breath, to make some of the assessments that that might not otherwise be made. So, and then the role of the counselors in knowing their patients and having patient history, past substance use history, and urinalysis, and that sort of thing. They, are critical in the identification of impairment in the OTP among their patients. So to maximize, moving along here and changing the slide, to maximize cooperation from patients in identifying patient impairment, I have some suggestions, and I need to say that I believe the patients themselves, having had this experience personally, are a most underused resource in helping to identify patients who are impaired or at risk of impairment. The problem is, obviously, there isn't a great deal of what's in it for me incentives in informing staff that they themselves are impaired or have taken something, or they know about another patient who may or is impaired. The incentives are often punitive and may, first of all, telling on someone else or ratting out is an one of the ethics codes of the street. You just don't do that. But I think that can be easily overcome if at least the disincentives for sharing this critical information were removed. Often patients lose their take home. Or are made to come in to the opioid treatment program more frequently, or otherwise, the consequences to the patient seem punitive. They definitely wouldn't be in the positive benefits, other than it being the right thing and somebody being in trouble, that sort of thing. So you really want to look at what disincentives exist and try to work with patients to figure out how to get rid of those disincentives, or at least possibly create incentives for patients to share true information about the existence of impairment in the OTP, or somebody who's relapsed or fallen off, or is otherwise using. There should be an incentive for patients to do that. It's an important source of information. It's a unique and underused. So one of the ways to do that certainly is to include patients in the whole process of developing policies and procedures around the issue of impairment. This is a community effort, and I often say my test is, would I want to be on the road with my children in my car with this person, And patients have children in cars too, so that's a question you might want to pose. If somebody's impaired in driving, there's a possibility you're going to be hurt, or someone you care and love will be hurt. So some of the reasonable inquiries, these are sort of the general legal standards that I use, because in general common law, not state to state specifically, the standard that I always resort to in giving advice just generically to people from various jurisdictions is a reasonable standard. Is this the reasonable thing to do? And if you act unreasonably, you're more likely to be held responsible for the consequences. So regular inquiries directly to all patients regarding what other substances and medications they are currently or have recently taken, it should become a norm, a routine, not just a thing that's done once and then never asked again, and you're relying exclusively on UAs, which patients are very good at disguising, and you really want to be asking and exploring that issue frequently and routinely. And then the second identifying inquiry is for new patients and patients known to be currently struggling with alcohol or substance abuse, especially those whose positive drug screens you have. Verbal inquiries, just asking, may not be enough to identify impairment or to meet that reasonable standard. It seems to me to be more reasonable to verify or validate an unknown patient or somebody you know to be struggling with additional affirmative action. And that may be one of the impairment assessment tools or any number of resources we have at our disposal to help verify the presence of impairment. Changing the slide to the risk treatment options for impairment. Some of the risk treatment options for impairment I'll just review, but then these are related to induction because we know that to be a time where there's an increased likeliness, of impairment occurring. The risk treatment options that you're ultimately going to select or devise or adopt are as a practical matter, they're going to be driven by the OTP's resources, your resources. How much it's going to cost to adopt a risk treatment plan. And that's okay. I really believe in this time of, and given our economy, even judges are, I think, conscious of the fact that many decisions are guided in part by what resources you have at your disposal. And I don't think anyone is expected to take, to make unreasonably expensive actions regarding risks that are relatively minor. So I think that's okay to acknowledge. It's not something that can't be discussed when you're talking about how you might want to treat patients during induction, new patients, to make sure that they're fine and not at risk hurting themselves or others. So one of the risk treatment options certainly is to accept or assume that risk, that you're going to have patients who are going to come in and you're just going to accept that they probably there is a risk of that they may experience some impairment either in withdrawal or over medication until that tolerance is built or matched. But you may have such confidence in your medical staff and the individualized treatment that they are known to practice that you're willing to assume that risk, and many OTPs will. Just my recommendation is just to do it consciously. You can also opt to limit the risk by making patients maybe stick around the program for the first full day, and then reducing the hours that they need to be there, so the docs can actually see patients when peak plasma levels are present, or impose a call-in process to check patients to see how they're doing at home during the first few days of induction. There's all kinds of variations on this. This is to just give ideas about risk treatment. So that's to accept or assume the risk. To try to avoid the risk would be another treatment option by abandoning or eliminating the source of the risk. In other words, you could insist that all new admissions will be limited to patients who have already been induced, or that they have, you're referring patients inpatient or to another program for induction. And that seems rather extreme also. These are just by way of example. And to move on to the next slide, this is where most of the risk treatment options come from, and that's in the mitigation area, which is like loss control. It's just more often the action, the risk treatment action to reduce or minimize risk, in this case during induction, would come via revised policy and procedures. And for instance, you can reduce the frequency, the likelihood, severity, or impact of the loss associated with impairment consequences from induction by implementing the policy, the no-tolerance policy that I absolutely endorse, and I just can't express how critical that is, that be known and be that the members of your program have a consciousness of it, that this no tolerance for impairment. That you can also, we talked about removing disincentives and punitive consequences for identifying patient impairment in patients themselves and in other patients. You can create incentives. We talked about this too. This would be a risk treatment and mitigation. Ask patients what benefits would encourage them to share information about patient impairment. With input from patients, which is what I always encourage and advocate for, revise established policies and procedures for for reporting suspicious impairment and for responding to it, because we need patients to know what the consequences of being or coming into the OTP impaired will be. So some of the impairment is not intentional, or even the consequence of illicit substance use. There oftentimes the impairment can come from a disease, an epileptic, for instance, or any number of sources that aren't associated with patient malfeasance. It's just an analysis, and it's a universal issue for everyone's safety. So moving along to additional treatment options to mitigate risks, you can defer dispensing patient medication until there's confidence that the patient is not impaired or at risk of harm. You can have them wait around and then reassess. You may use one of the assessment tools, impairment assessment tools, and then reassess 4 hours later. Oftentimes patients will leave rather than wait around, and that's where you need to make a call as to whether or not the patient is safe or at risk of harm to self, either on the street or if patient's about to drive.
Lisa?
Yes.
Yeah, this is Tony. I just wanted to give you a heads up, 10 more minutes.
Okay.
And then we have at least one question at the end.
Okay.
Okay?
So we want to make sure with these that patients intending to drive away against medical advice, who are unmedicated, hopefully, but potentially, possibly impaired. Perhaps you haven't verified it. You need to consider whether your state or municipality has passed laws imposing affirmative duties to report to either local law enforcement or the DMV or or some other agency, in which case you really need to consider confidentiality laws and may need to consult with your legal counsel about how to go about reporting, complying with the reporting requirements without breaching confidentiality, or which law trumps which, who comes first, and that sort of thing. The next slide is gives the elements for malpractice and for third-party negligence. And I think I'm not going to spend a lot of time on this. I just think there are 4 elements, and one of the things that's become an issue today is that the duty that is owed by OTPs to their patients to deliver care has been expanded to persons who are foreseeably endangered by the breach of the duty owed to that patient. So I'm not sure how that's going to be received, but it's basically if a patient is coming through your OTP and leaving impaired, it's pretty, and driving, it's going to be foreseeable that there are potential victims, unknown victims. And so that's one of the reasons why we're having this webinar, and one of the reasons why the no tolerance for impairment theme is being stressed over again. And I'm going to skip the third-party liability. It just goes into a little history, and that we'll go to the summary of the legal standards, because I think this will help. I've got 2 slides left, and that's really amazing for me to get through one of these things. I usually have slides left over. Excuse me. So, summarizing, OTPs need to take proper care and all precautions to use reasonable care to ensure that a patient is not impaired prior to administration of methadone. The cases have reached out and actually allowed cases to proceed to a judge and jury for medicating patients where it was obvious to other witnesses that the patient was impaired. The OTPs also need to take reasonable precautions to inform patients of the side effects of medications prescribed and or dispensed, which is a part of the patient consent procedure, and to prevent the impaired patient from driving. And again, that may include reporting to various officials. Next slide is, once impairment is identified, the legal duty to take action just means that you can't ignore it. You can't then later claim we didn't know. Ignoring evidence of impairment that is in plain sight of others, you're actually legally charged with should have known, and the same liability attaches. It doesn't. Liability, the lawsuits don't extend to patients who become intoxicated after leaving the OTP. In cases where the program was provided no indication to or reason to suspect impairment or an opportunity to intervene. So, in conclusion, with the final slide, opioid treatment programs knew or should have known, which means you're going to be charged with the knowledge that case law is extending a liability for harm to third parties caused by impaired patients who are coming through your methadone program and then driving, where there were plenty of red flags from which to conclude or at least suspect impairment. There is case law that has held programs liable for medicating. I just spoke about this, despite knowledge even if even if it wasn't officially acknowledged, but it was obvious to other folks who were in your OTP or around it. The failure to take reasonable affirmative action to prevent or intervene. And the opioid treatment programs are charged with knowledge that when evidence of impairment was ignored, for instance, urine screens, reports of patients stumbling online, that sort of thing, always resort to the reasonable standard. What would a reasonable physician do, or opioid treatment program, or what would the reasonable action be under the circumstances? I think it's pretty safe to fall back on, but here again, I'm going to end with just really urging everyone to consult with local counsel about your reporting obligations and thus the law in your state, whether or not your state has contributory negligence, which means if you were found liable for some of the harm, it's apportioned between your relative. You may have the patient may have caused some, the victim may have be responsible, and so liability is apportioned, which is a lot different than all or nothing. And I wish you well with this issue. I think it's ignoring it or not responding to it reasonably to get it under control really threatens the future of our methadone treatment programs. And I have confidence that the programs will respond, and we can put this issue into context, notwithstanding some of the actions that are happening that seem adverse to methadone. I have confidence we will overcome this. So thank you very much, and I defer now to Dr. Stile.
Thanks, Lisa. That was great. There's one question that I wanted to let you answer, and then we'll move on to the second part, which is my talk about some of the clinical aspects of assessment. The question is this. Pennsylvania is currently proposing legislation, certain members of the legislature, to restrict driving privileges for patients enrolled in methadone clinics. Are you aware of any other state that's taken this approach, and if so, what has been the outcome?
No, I don't know of any other states per se, but I haven't put that through a legal search. However, I was just up in Maine, and one of the things they do that's just as offensive is if you are on a medication that restricts driving, you have to report to the motor vehicle department, and you have an M stamped on your license, which is, to me, it's just as offensive. And it presumes that you're not going to be that we're not responsible people. And the other thing is, with methadone, and I really didn't have the time to get into it, the fact that we have so many patients who are stabilized and are opioid abstinent, and this is our ideal and our objective, we need to start advocating together on a legal basis that it's discriminatory to act otherwise. A law that there are like 14 states, or I forgot how many states, that have these laws that, per se forbid people to drive when you have a medication that you're not supposed, that says you're not supposed to drive, and just having that medicine in your system is enough for a violation, and that's just not fair, because people they respond to medications uniquely. Everyone is unique, and to have these broad-based policies and laws are just it's just offensive, and it's crippling. So I think in Pennsylvania, for example, we really need to come together and to bring some testimony and some of the expert research and other evidence we have about opioid abstinence. And, we need to take care of the impairment issues individually in our OTPs, as I said, with this no-tolerance policies. But that's a great question, and this is a great concern, and it's one of the reasons we're having, a webinar on impairment, because there's a lot of misinformation about, methadone and impairment, unfortunately. So I don't think I answered your question, but
you did fine.
I think we all need to formulate some legal response to that.
Okay. Well, thank you. That was the only other question. I'll start with mine. You're welcome to stay on, and I guess at the end, if there are questions, you and I can both answer them, and or summarize towards the end of the talk. So
I'll stay on. I'm just going to mute it.
Okay. I did want to thank both SAMHSA and CSAT, by the way, for their ongoing support of these seminars. We've had 3 webinars and a full-day conference, and this is the 4th webinar on issues related to safety in regards to programs that provide methadone to patients with opiate dependence. So I think this is a very important, as Lisa said, very important to get the data, to make our decisions data-driven, evidence-based, and where there isn't evidence, to try to insist that we get evidence. It's sometimes difficult to find more recent studies on methadone, although it is a very studied medication. So. But moving on, we're talking about assessment for impairment. Really what we're talking about is an index of suspicion. Obviously, it's a high-risk behavior for individuals who are prescribed methadone for treatment of their opiate dependence to possibly come in one or another state of impairment. One area that Lisa identified very clearly was that whole period of induction. And most of the studies I've been able to read on induction and impairment in driving in particular had to do with naive patients naive to opiates, and patients naive to methadone, who were put on opiates for pain or methadone for treatment of opiate dependence. And then they were given the opportunity to take simulator tests of driving. And the real impairment, if there was, by the way, impairment, the real impairment was the first few days, maybe up to a week, which we all pretty much understand are critical periods that we have to be more observant anyway. Beyond that, once there was tolerance developed, there really was not a big difference between control and opiate receiving patients in their ability to drive in a simulator. Now, given that's not an automobile, but it does give some indicator. We got to look at history of recent prior episodes. Obviously, if somebody's out of control, they're going to be more likely to come in under the state of intoxication. If we observe the smell of alcohol, or if on a routine blood alcohol concentration determination we find an elevated BAC. If we do on-site urine drug screens, which in some instances are just to see how people are doing and really are not confirmed at that time or not evidentiary, but are done on site to see how folks are doing. If there's a positive urine drug screen, that's a common trigger for assessment. Obviously, reports from other patients, and Lisa makes a good point that other patients very often will know, if not that the person's impaired on that day, that they may be using substances. And I've never found in my experience at the NATP for St. Francis that patients are hesitant to report. Actually, patients will report, and then you're in the situation where you have to protect their anonymity, but at the same time, then increase the observation of the patient that they reported on, so that you can determine is there current impairment. Obviously, staff observation, any staff, all staff, including the security guards, which we have in Pennsylvania, all the way up to the payment clerk, to the nursing staff, the counselors, the physicians, they all need to be alerted and trained, and all patients, as you point out, both in the initial risks, benefits, and alternatives description of methadone, as well as ongoing, need to be informed. But when push comes to shove, behavior reveals the altered mental status, and that's really what you're looking at. That's the reason for the assessment. Now, you're really doing a mental status assessment in many ways, plus a neurological exam. You're assessing for indicators of intoxication from either opiates and/or sedatives and/or stimulants. And we'll talk a little bit about that. Another common cause of impairment isn't intoxication, but rather is withdrawal. And so using the clinical opiate withdrawal scale, the COWS, or the CIWA, AR, the Clinical Institute Withdrawal Assessment for Alcohol Revised, really is important to have them available and be able, during the assessment, to call on them and do those assessments, because sometimes impairment isn't from intoxication, it's rather from withdrawal. And then there's always the assumption that whatever impairment is due to substances, either intoxication or withdrawal, and that isn't necessarily the case. You know, many of these folks come in with co-occurring medical problems. They come in with diabetes. Hypoglycemia certainly can show a state of impairment. Recent head injuries, you know, these folks often are involved in activities where they get injured, and, you know, recent head injuries can cause that. So I think we should not always assume that substances are the common cause, and at all times document. I mean, that's very important. Just to review some of the signs of stimulant intoxication, really it's like having too much adrenaline. You're talking about dilated pupils, and sometimes the amount of stimulant that's taken will offset the pupillary constriction that you're going to get from the opiate, and cause at least mid-range and maybe even dilated pupils. So it's worthwhile looking at the pupils if you're going to do an evaluation of impairment. Another area, by the way, where pupils are highly important to look at is in people that abuse meperidine, Demerol, because meperidine or Demerol is going to cause dilated pupils and may be a sign of intoxication with that. Sweating, often with chills, high blood pressure, so the vital signs are important. Tachycardia can occur with acute stimulant intoxication. Hyperthermia, elevated temperature. Keep in mind, when a person is put on methadone, one of the initial things that happens on methadone is a slight lowering of the basal temperature. And so if they come in with a higher temperature, then you have to really look at that and figure out what that's from. Bruxism or teeth grinding, tremors, and even seizures can occur with cocaine abuse, particularly intravenous cocaine abuse. So you need to be aware of those and look for them, and you need to correlate acute stimulant intoxication with the expected effect of methadone, since these are patients that are on methadone. Now, opiate toxicity is a little different. You're looking at depressed levels of consciousness. Opiate toxicity should be suspected when the clinical triad of CNS depression, so sedation, lethargy, respiratory depression, so there again the vital signs are very important, and pupillary constriction or meiosis are present. Very important. Drowsiness can occur, conjunctival injection can occur, and euphoria can be seen. So don't assume that every one of these patients that come in, if you see them euphoric or even slightly manic, that they're not impaired. They could be impaired from stimulants, or they could be impaired from the intoxicating effect of opiates. And then finally, and this is, I think, very important, a recent use of a sedative hypnotic anxiolytic, and I use those three terms because that's basically what the DSM-4 classifies these drugs as, because at some dose they're sedating, at another dose many of them will cause sleep, and at another dose many of them are anxiolytic or fight anxiety. But you're looking for clinically maladaptive behavior, you're looking for slurred speech, incoordination, unsteady gait, the possibility of horizontal gaze nystagmus, not just nystagmus, but horizontal gaze nystagmus. Now, the difference is if you're looking up or down and you see nystagmus, then you may be dealing with phencyclidine. or ketamine, or even high-dose morphine. The class of substances that's almost always associated with lateral gaze nystagmus, and we've included in the attachments how to do a test for lateral gaze nystagmus. But the class of substances associated with lateral gaze nystagmus is sedative hypnotic anxiolytics, okay? And so if you see that, it's an indicator of you should be looking further for sedative hypnotic anxiolytic impairment. Impairment of attention and memory, and then all the way down to stupor or coma. But always consider, this can be from a medical cause. You know, we have a saying in medicine, if you hear hoofbeats in Pittsburgh, don't look for zebras, which is probably true. I don't know that you look for horses in Pittsburgh anymore either, but certainly don't look for zebras. But we do have a zoo, and maybe the zebra escaped. And so you can't rule out the possibility of a medical cause, even if you think this is from intoxication or drug withdrawal. Drug-drug interactions, very important, Lisa, I agree with you. There's two ways that drug-drug interactions are going to be considerations. Number one, we already said that withdrawal can indicate some impairment or can lead to some impairment. And there are many drugs, both prescription and over-the-counter, that can lead to a speeding up of the metabolism of methadone and therefore withdrawal from methadone. The ones that were on the bottle when I was as medical director at St. Francis were things like Talwin, Stadol, buprenorphine, and rifampin, the anti-tuberculous drug. So drug-drug interactions with those kind of medications may cause withdrawal, and that may be associated with impairment. On the other side, many medications can interact synergistically or at least additively with methadone and cause sedation, cause increases in methadone levels. Luvox, for instance, is notorious for that. Even drinking a lot of grapefruit juice can have an impact on some of the metabolism of methadone and increase the methadone levels. So can be a medical cause, can be drug-drug interaction. Obviously, substances are very common as a causation, either substance intoxication or withdrawal, but don't always assume that. Impairment is the issue, even if it's accidental, even if it's by prescription, even if they went to their doctor and the doctor gave them something and the doctor wasn't aware that it interacted with methadone, or the patient didn't tell them they were on methadone. Special note on prescribed medication. Obviously, there's an entire webinar or all-day conference that we could be holding on your policy regarding benzodiazepines, okay? But regardless of what your policy is on prescription medication, specifically benzodiazepines, other opiates, or even psychotropics, as you mentioned, Seroquel and Luvox are two. If their use is involved in the current state of impairment, it has to be dealt with right now. The impairment is right now. The treatment plan can then be amended to deal with the long-term issues. And again, that's based on your policy. Some process suggestions, right? Some of this will just reiterate what Lisa has said. As a clinic policy, you should say no toleration of impairment, and you communicate that policy to the patients, and you communicate it to them regularly. One of the things that Lisa talked about in another seminar, which I thought was really excellent, was getting consent before the issue. Getting an informed consent by the patient before anything happens, saying that if I come in impaired and you think I'm impaired, you can notify my family, you can notify a particular person. Obviously, you got to get prior consents to notify anybody, but preparatory consents may be a very important thing. Also, preparatory evaluations. One of the things we're going to talk about later on is how to do the assessment for impairment. And if you've previously done an assessment, for instance, the MOCA, the Montreal Cognitive Assessment, and you have a baseline of their ability to write a sentence, their ability to do a figure, their ability to sign their name, you can then use that later on if you think there's impairment. Documentation has to occur whenever there's an index of suspicion, and it should start from the beginning. You shouldn't have to catch up. You should start right from the beginning. Obviously, privacy and confidentiality has to be maintained during this. You don't want to embarrass people because, number one, you may not be correct. They may not be impaired. And number two, even if they are, privacy and confidentiality has to be maintained. And then ultimately you have to reflect in your treatment plan what you've done, what you've found out. Obviously your choices are to medicate, and if impairment is from withdrawal, you may choose to medicate, and that will be what you document. You may medicate but ask the patient to stick around for a while, monitor them. Usually 2 to 3 hours after they take their methadone, they're going to peak their dose, and you're going to be able to see whatever maximal effect there may be, or in certain instances, the maximal effect. You can say, look, we're not going to medicate you right now, but stick around for 2 or 3 hours, or 20 minutes, or a half hour, whatever you think is an appropriate amount of time, and monitor them. Or you can decide not to medicate them at all. At that point, if you have the preparatory consents, you can arrange for transportation home. And I think Lisa already dealt with the issue of if the patient refuses to stay and wants to drive and they're impaired, what you might be able to do at that point. Now, the examination starts with observation. That's your index of suspicion. You should always engage in a respectful conversation to further promote the evaluation, to talk to the patient. See if you smell alcohol on their breath. See if they're incoordinated or slurred or illogical in their speech. You make a decision on whether to further test based on clinical data. Not just on patient report, not just on staff report, but on clinical data. I think you should explain the reasons for the testing to the patient in private, confidentially, and even, this is my idea only, have a script. Because you're going to need to train all the staff in terms of interventions. You're going to need to make sure you train and document the training for your nurses who are going to be doing these evaluations, for your physicians who are going to be doing these evaluations. So maybe developing a very brief script so you say the right thing at the right time to the patient, and you do so in a very consistent way. Always maintain privacy and confidentiality. Results should be reflected in the treatment plan. Take-homes are very important. It may be that this individual's impairment's from withdrawal, in which case you medicate and you don't necessarily alter their take-homes. It could be that it's from intoxication with illicit substances, in which case you are going to address their take-homes. Specific testing may include the MOCA. I mentioned the MOCA rather than the mini mental status exam. Both are excellent. Both are good in identifying cognitive impairment. The MOCA is public and so can be used without copyright problems. The mini mental status exam should only be used if you've had previous approval and permission to use it through the individuals who developed it. Blood alcohol concentrations, urine DUG screens, and neurological exams. One of the areas that is important to remember is when you're doing an assessment of impairment, you're going to look at things like memory, orientation, judgment, intellectual capacity, and affective expression. Those 5 areas, memory, orientation, judgment, intellection, and affect, are essentially the areas that are affected in the mental status examination by organic changes. Memory is important because keep in mind, many of the drugs of abuse, and I'm including here alcohol, the benzodiazepines, and the barbiturates, there may be an ability to show good immediate memory. So you say, repeat this number after me, 345, and they say 345. Remote memory may be intact because they know how to get there to the program, they know who you are, they know who the therapist is. It's the recent memory disturbance that you're worried about with alcohol, benzodiazepines, and barbiturates. So you ask them 345, they say 345, 5 minutes down the line you ask them what are the numbers, they don't even remember being asked the numbers. And so you have to be aware that some of these substances are going to impair certain parts of memory while not impairing other parts of memory. Orientation. We learned in medical school that there are actually 5 levels at least of orientation. Needed a little drink there. Time, place, person, which we all know about, and obviously time, place, and person. You begin by talking about micro time, micro place, micro person. You know, micro time meaning what time is it, what day of the week, what date of the month, what month of the year, what year, that sort of thing. Place, where are you today, what city's it in, what state's it in, what's the name of the country. Person, who am I, who are you, who's that other person. So you're looking for micro time versus macro time. microplace, macroplace, microperson, macroperson. You're also looking for their ability to orient themselves in the situation. What are they there for? Why are they there? What's the situation? And then finally, spatial orientation. The ability to do a figure, such as the Bender-Gestalt figure, such as in the MoCA or in the mini-mental status exam. Their signature is really very important. Their ability to write their name in a smooth manner, and if you have previous signatures that you're able to compare it with, that's very important. In the MoCA and in the mini mental status, there's also write a sentence, and so you could compare it with that. So spatial orientation is very important. Judgment is really the ability to sequence, and if they can't seem to put it together, 1 leads to 2, leads to 3, leads to 4, then that's an impairment of judgment. Now, the psychomotor status you want to look at, and keep in mind, impairment isn't just on the sedated side, being stuporous or conscious but drowsy or having some psychomotor retardation. It's also being hyperalert. You know, cocaine, other stimulants are going to cause hyperactivity, hyperalertness, and that may be an impairment as well. Are they cooperative? Are they combative? Mood and affect. You want to look at how are they relating with you. Is it in an angry or irritable or hostile manner? Is it in a calm manner? Are they anxious? Are they panicky? Many times coming off of sedatives, you know, many of our patients will do what we tell them. They're coming into a methadone program and they're going to discontinue all medications, often abruptly. So they're going to discontinue their opiates and we're going to replace that with methadone. Some of them may discontinue heavy use of alcohol, heavy use of barbiturates, heavy use of benzodiazepines, and 2, 3 days later, 4 days later, show panic attacks, hyperanxiety, irritability, basically associated with withdrawal from sedative substances. So mood and affect and their expression of mood and affect is very important in determining organic states. Are they elated? I mean, is this a bipolar patient who's been off their medication because you told them to stop all their meds, and so they quit their lithium or they quit their Depakote or they quit their Seroquel, and now they're hyper elated because they're having a manic swing. So you want to make sure you evaluate the emotional expression. Speech, as mine is rapid, some people's is very slow. They come in either intoxicated with a sedative or withdrawing from a stimulant. And keep in mind, there's a similar clinical status when somebody's intoxicated with a sedative or coming off of a stimulant. They're going to look slow, deliberate. There's going to be some psychomotor retardation. There's going to be some slurring, perhaps, in intoxication with sedatives. If they're high on speed or cocaine or amphetamine or methamphetamine, then they're going to be speaking rapidly. If they've been on a binge, they may be speaking illogically. Or is their speech relatively spontaneous? Now, there are some neurological tests that you want to at least consider putting in your document, because you want a document to be able to track what's being evaluated and how the patient is doing. As I said, horizontal gaze nystagmus is extremely important. Sedative hypnotic anxiolytics, including alcohol, benzodiazepines, and barbiturates, typically affect the eyes in such a way as to cause a nystagmus, which is an uneven movement of the eyes in the horizontal direction, in both directions. Okay? Now, if you see it in one direction and not in the other, that could actually be something in the inner ear. If it's in both directions equally, both looking left and looking right, it's more likely to be a sedative hypnotic anxiolytic. Actually, alcohol has a number of very specialized types of nystagmus. There's what's called positional alcoholic nystagmus first phase. There's positional alcoholic nystagmus second phase, and then there's rotary nystagmus. So somebody drinking really heavily, some of you may have friends who remember this, somebody drinking very heavily, as they try to lay down after they've been drinking heavily, when they get to about 45 degrees to the bed, they begin to have vertigo, their eyes begin to move back and forth, and that's called positional alcoholic nystagmus. So alcohol in particular, but also benzodiazepines, barbiturates, and to some extent cannabis can cause the horizontal gaze nystagmus, and we've included in our attachment how to do it, what are some of the positive findings, and it's actually included in the field sobriety test. So that attachment is there. You want to look at the pupils. Are they constricted like they're supposed to be in somebody who's on methadone and is well maintained on methadone? Are they dilated? Shouldn't be dilated in somebody on methadone. Are they uneven? That really is a neurological sign that is not very good. Do they react? In other words, if they are dilated and you shine a light in them, are they very slow to get smaller? Because they should get smaller if you shine a light in them. Or are they unreactive? So these are some things that you really need to look at. The walk and turn is a coordination test. You have an individual walk towards the door and you say, wait a minute, turn around, and then they're supposed to turn around and walk back. And you see what the coordination is. The one-leg stand is their ability to stand on one leg. Now, the Romberg test is interesting. That's a coordination test, testing your ability to stand with your feet together and your hands at your side with your eyes open and not sway back and forth. And then if you close your eyes, the ability to maintain that posture without excessive sway or stepping to the side because you've lost your balance. Romberg test, very, very good test for showing motor impairment, and that's really what we're talking about here. There's memory, orientation, judgment, intellection, and affect that shows mental status impairment. The Romberg, the finger to nose, the horizontal gaze nystagmus, that's showing more motor and neurological impairment. And the finger to nose is very easy. You have a person stand, fingers out to the side, close their eyes, come in and touch their nose like I'm doing. I don't know if you can see me as I'm doing here. And if you're able to do that, then that's an important sign that you're not impaired, at least in terms of your coordination. Vital signs, real important. Temperature, as I said, if you're on methadone maintenance, what's going to happen? Temperature's going to go down a little bit. If temperature's up, that's a signal. Pulse should go down a little bit if you're on methadone in an appropriate dose. If the pulse is rapid, could be withdrawal causing that impairment. Could be stimulants causing that impairment. Respiratory rate, again, on methadone should be slowed, okay? Should be slower than the normal 12 to 16 respirations per minute that you might get. So if the respirations are slowed, then that would be appropriate. However, if they're too fast, then you worry about what is causing that. Systolic blood pressure, that's the upper number, should be within the normal range, 120 or less, unless the person has systolic hypertension or some sort of hypertensive problem. Diastolic blood pressure generally should be below 80. If it's above 80, there again, you're talking about the possibility of stimulant abuse, anxiety can cause that, or essential hypertension can cause that. My point being, you want to look at, as part of your impairment assessment, the vital signs: temperature, pulse, respiration, systolic and diastolic blood pressure. So, having spoken very quickly and getting to this point a lot quicker than I thought, and having no questions, if you have questions, by the way, please feel free to send them through the normal route of sending questions. I want to summarize, and then we'll see if Lisa has any final things to say, and then we'll close. Anyway, my summary is this. All staff, and I agree with Lisa, patients, the patient who's impaired plus the patients that are in the program, we all have a role in determining an index of suspicion for impairment. Number two, there really should be a very clear policy that's communicated to all the patients regarding impairment. And I feel that, as a suggestion, preparatory consents for just in case this happens. If I'm impaired, you can contact a family member. Those kind of preparatory consents might be a good idea to look at. A documentation tool, something that's either circle or check off, or a template that you have to fill in, a certain number of areas. A script, perhaps, to make sure that you are saying the right things to the patient in the right way. And then finally, training. You have to train your nurses, your doctors. You have to train the rest of the staff so they know what's going on and what's going to occur. At all times, privacy and confidentiality has to be maintained. And that can be part of the script. Part of the script could say, we're not going to medicate you right now, but we want you to meet with the head nurse. Would you go over to the head nurse's office and we'll talk to you further over at the head nurse's office. Not to raise suspicion, not to embarrass the patient. It may turn out that they aren't impaired, in which case you've been safe and rather safe than sorry. But the point is, it should be private and confidential and obviously respectful. You've got to document the process. And you have to alter the treatment plan if the impairment is present or if there's other areas that are identified. Even if it's withdrawal that's identified, you have to alter your treatment plan. Over and above, you have to make choices that are consistent with safety to all. The individual patient, other patients in the program, people on the street, patient's family, individuals who are on the road when that patient is driving, etc. But the choices should be consistent with safety for all. Okay. Lisa? Yeah.
Can you hear me, or am I muted?
No, you're still on. You're on, and I hear you.
Oh, I thought that was a wonderful presentation. I really, I learned a lot also. I just wanted to underscore the privacy and confidentiality, but also that when you're suspicious and possibly even before you begin an assessment or any kind of information, I would just make sure that you get your suspicions confirmed by and involve another staff person, so it's not just one person making that decision. Right. And that may be, presumed, but I just wanted to add that just for the record. Mm-hmm. And that's about it from me. Okay. And actually, that's it for me. We're ending a little bit early, but if there are any questions, the only one I saw is from Rob, but other than that, we will close. Now, you can visit www.ireta.org. You can view this starting Monday, April 5th. Don't forget, today's Good Friday, and then we have Easter Sunday. So April 5th, things will be on, and it'll be after 5 o'clock Eastern Standard Time. I would remind you that we do have other webinars. There's the original webinar, which is a 2-hour webinar. Then there's the entire full-day conference, which was held in Chicago a couple of months ago, and they're both available on the web. We also have the clinical toolbox. Now, that toolbox is growing. It includes things like the documentation tool. It includes how to do a Romberg, how to do a finger to nose, other than what I showed you. It includes things like the horizontal gaze nystagmus test and the other test on a field sobriety, including, and then other things from various sources. So I would encourage you to go on that clinical toolbox. If you do have questions that didn't come up during our presentation, please get a hold of me through ireta.org, www.ireta.org, and put it to my attention, and it'll get to me. So with that, I again thank SAMHSA and CSAT for their ongoing support, and we will close the webinar. Thank you.